The first presentation will be on the role of Brolucizumab in neovascular AMD and PCB. So why we wanted to bring out this IC was that the icicles were getting larger. And what are these icicles? When we looked at our data of the intravitreal injections that we had been injecting at Army Hospital RR, we found a very interesting trend. From 2018 and 19, where the predominant injection used to be ranibizumab, the trend was changing towards aflibercept and brolucizumab. Why this happened was an obvious reason, because this was the trend all across the country. But very interestingly, we found a rising trend towards brolucizumab because of its longer lasting action and cost effectiveness compared to aflibercept. These are at present the established usages of brolucizumab. I'll be speaking about AMD and polychoroidal vasculopathy, while my colleagues will be speaking about diabetic retinopathy and few of the novel applications. In these novel applications, we'll be covering a gamut of indications. So why we are calling it the Indian experience? Because when we talk about brolucizumab in India, the first study which came out establishing RCTs confirming the efficacy of this molecule was from our institute. Like the rest of the country, we also had initial setbacks with some severe IOIs. But as of date, we have completed 1,770 injections, and we have only had 4 serious IOIs, which have all been well managed, and none of our patients have lost vision compared to the baseline from where they started. Why this molecule behaved differently in India? This is probably the only reason that we have, because otherwise there is nothing different in the molecule which is manufactured here compared to elsewhere. So initially I'll bring you to our study which changed the mindset of our doctors in India toward this particular molecule. Where the West was reporting 4% serious IOIs, we encountered less than 1% serious IOIs. We took necessary approvals for the study, and our inclusion criteria were the same as Hawk and Harrier, and we were targeting the population with best-corrected visual acuity less than 6/9 and more than 3/60. I'd like to highlight this point here, that few of our colleagues have been trying to achieve success in burnt-out cases with less than 3/60 vision with multiple injections of brolucizumab. We have to understand that beyond a certain level, these drugs will not work. Our exclusion criteria initially tried to rule out any evidence of intraocular inflammation in the cases that we were injecting. Again, I like to point out here that with our experience, we have realized that once the inflammation has completed its course and you are faced with an inflammatory CNVM, you can still go ahead and try this molecule with decent results. So it was a well-randomized trial. The protocol that we followed was 3 initial loading doses at 0, 4, and 8 weeks, followed by 4 weekly reviews. And at the 4 weekly review, whenever we found that any patient was meeting the retreatment criteria of 1 line drop in vision on logMAR or a OCT increase of 75 micrometer of central macular thickness or appearance of new IRF or SRF spaces, we were injecting. The same treatment criteria we recommend to be followed by everybody else when they are trying to re-inject brolucizumab. One very important thing which we wanted to study was the ocular adverse events. Grade 1 and 2 events occur in any intravitreal injection. What we were interested in were the serious IOIs, where we required topical or oral steroids, And grade 4 were the serious IOIs where you needed oral steroids, which were the ones we focused mainly on. I'll be talking also about the 2 serious IOIs and how we managed it. Our patient characteristics at baseline between the 2 groups were quite well matched. We had about 56 patients in Brolucizumab arm and 58 patients in aflibercept arm. We had a slight male preponderance being a service institute, and the best corrected visual acuity and central macular thickness at baseline was well matched between the 2 groups. In addition to the central macular thickness, we were also looking at the fluid compartment on OCT in each of these cases. The best corrected visual acuity and the central macular thickness, as had been predicted by Hawk and Harrier, improved, though there was a small incremental benefit compared to aflibercept, but it was not statistically significant. So we started looking at how the central macular thickness was decreasing between the 2 groups, and when we looked at the fluid compartments, the intraretinal fluid compartment and the subretinal hyperreflective material, they behaved almost same between the 2 groups, but the subretinal fluid was the important part where we saw a tremendous decrease compared to aflibercept with brolucizumab. So this established a better drying effect, and in a patient where you tend to achieve a wow factor, a patient with subretinal fluid is the ideal candidate. Another question which needed to be answered was that how many re-injections were required in these patients. So after finishing the first 3 loading doses, we tried to calculate that when were the patients being re-injected in the 2 groups. With this data, you can make out that most of the re-injections in brolucizumab group occurred between the interval of 12 to 24 with a mean of 14.4 week interval, while in the aflibercept arm, most patients were still receiving re-injection at 4 to 12 week with a mean of around 6 weeks. Talking about the intraocular inflammation, we encountered 1 serious intraocular inflammation in this subgroup. So what we learned from our experience was that brolucizumab worked as well as aflibercept. With our larger experience now, we believe a shade better, provided longer inter-injection interval, though it caused significant adverse events when we looked at the patient in a close follow-up manner, but they were all manageable. And I like to point out here that what most studies have brought out, including our study, were type 3 IOIs or grade 3 IOIs, where you see a lot of cell and flare, but most of these patients are asymptomatic. Patient never tells you that I have an issue. It is simply that you are calling back the patient every 4 weeks and subjecting them to a detailed examination, you are able to pick up these cell and flare. So we established the lower number of injection and lower number of serious adverse events occurring with brolucizumab. I'll talk about the patient who suffered the serious IOI. Why so? Because it's important to know the other aspect of the drug as well, that what happens when this drug does not behave. So we had this 65-year-old lady, started with pre-injection best-corrected visual acuity of 0.62, and 72 hours after the injection had this picture. So the moment you see 72 hours prior to injection hypopyon, the first thought which comes to your mind is that this is an endophthalmitis. So we started prepping up our intravitreal antibiotics, but we paused for a minute and thought about the so talked about serious IOIs with brolucizumab. We held back the intravitreal antibiotics, started the patient on oral and topical steroid, and this patient did well without requiring any intravitreal antibiotics. So this was not an endophthalmitis. This was one of those talked about severe vitritis episodes. For 8 months, the patient was not on any anti-VEGF, and after that, now patient has started reusing aflibercept. We never had the heart to start the patient on brolucizumab again, and has a best-corrected visual acuity of 0.44. Now, compared to this, the second serious IOI, this we came across after our study had finished, was in a 72-year-old man who started with a pre-injection best-corrected visual acuity of 0.28, developed the vitritis 2 weeks after the 6th injection. So it is not defined that whether the person will develop an IOI after first, second, or third injection. It can be as late as sixth or eighth injection. And the time duration between the injection and the appearance of the IOI can vary from 3 days to 3 weeks. This again resolved by 5th day with treatment. And in this particular patient, we were able to restart the patient on Brolucizumab because this patient was extremely happy with the outcomes of the injection. So now what we have brought out new in this IC is we'll be showing you a 2-year follow-up of our neovascular AMD patient data, which were there in our trial, with a subset analysis of PCV. We are also planning a prospective study on PCV now. So we lost about 4 patients in the Brolucizumab group and 3 patients in the Aflibercept group when we came to 104-week follow-up. The baseline demographic characteristics remained the same. When we talked about the best-corrected visual acuity and CMT at baseline, they were almost similar to where we started from. Those loss of 3 and 4 patients did not make a difference. But this is interesting. At 48 weeks, we see that Brolucizumab group had a 0.13 improvement on logMAR at 48 weeks, and the same effect was retained till 102 weeks, while the Aflibercept arm had a 0.10 improvement at 48 weeks, and it became 0.09 at 104 weeks. This difference may look very trivial to you, but what is interesting is that the number of re-injections which were required to achieve this kind of result. So our patients in Brolucizumab arm at end of 102 weeks had 152 injections, while in Aflibercept arm, they had required 328 injections. So this is what we have been talking about, that once you have more number of injections, the true intravitreal injection-related ocular adverse events will far outweigh the number of IOIs that you will see because of the molecule itself. When we talked about our PCV subgroup, we had 18 patients in the Brolucizumab arm and 23 in Aflibercept arm. Please remember, this is the retrospective analysis of those OCTs. And the best-corrected visual acuity was a shade better compared to the rest of the patient and was even better in the Brolucizumab arm at baseline when we started. But when we talk about the change in best-corrected visual acuity, we realize that the stronger drying effect of Brolucizumab was seen in PCV cases also compared to Aflibercept cases. And the story repeats itself that the number of re-injections after the first 3 doses continue to remain low. Just to bring out that how much do we trust the molecule today, this was a standard case of PCV, had developed a subretinal rebleed. You can see a scar with a fresh rebleed there. And this was about 12 days old. We went ahead and gave a subretinal cocktail of TPA, Brolucizumab, and an air bubble. And this patient achieved a post-surgical outcome of 6/36. So to conclude, the best-corrected visual acuity gains are better than Aflibercept. There is a greater drying effect. The number of re-injections continue to be lesser, and there is a better action in PCV subgroup, at least in our limited sample. And the adverse events, when they occur, are manageable, and they are far less compared to what had been reported earlier. I was speaking to Dr. Dudani from Mumbai in the morning. He said that he recently had a serious IOI, but he also believes that the way forward is to continue giving the injections. Thank you so much. There's our contact. Any questions at this point of time, or we'll take them after the first 3 presentations?
I'll just ask a question for benefit of others. Brolucizumab, one concern is always IOIs, but your big data shows that the concern is not that severe. But like in your case of that 70-year-old lady, what could be the pointers that it is not because of endophthalmitis, but it could be because of the drug itself? In that case, could you formulate some kind of pointers where it is related to the drug?
We have experienced 4 such serious IOIs till now. One very important thing is absence of pain. all 4 patients, 2 were in diabetic patients and 2 were in AMD patients. None of them complained of pain. Patients complained of diminution of vision and redness. So absence of pain, probably in our experience, was a significant pointer towards the event being related to intraocular inflammation, not attributable to infections. Yes, please, ma'am.
You for an excellent presentation and the great work that you guys are doing. And I wanted to know about, you're giving a cocktail. Now, in the cocktail, how much of each thing is there and how much are you injecting, the volume?
So what we are giving is 25 microgram of TPA, half dose, that is 0.03 ml of Brolucizumab compares to about 3.6 milligram total dosage, and 0.06 ml of sterile air. So the total volume which gets injected below the retina is 0.12 ml. So that you saw the bleb. And in addition, when you are injecting this, a little bit of this cocktail will definitely bubble out into the vitreous cavity through the same aperture from where you were injecting. So 0.12 ml is the bleb which is formed below the retina.
Is it easy to calculate that much?
Oh, yes, ma'am.